So our case study is a classic thing. We do a lot of elderly care work in our practice. We do house calls so that people can get the care. Then we do phone medicine when necessary. But we're trying to use this as a case example in the current healthcare system. We know that many people end up in the hospital when they're older after a fall. And falls are a huge problem and often have preliminary symptoms prior to a fall. And so that these things could have perhaps been detected sooner than ending up in the hospital with hip replacements. So in this example, we have Mrs. Smith, who's, did we say she was 85? Did we give her an age? 85 years old. And she has poorly controlled diabetes and gets a lot of urinary tract infections, which is a common reason for people to get confused, and it's a very common reason to become unstable as you're older. And in this case, it resulted in her falling and breaking her hip and being discharged out of the hospital later. And the answer is, I think the question of our panel was going to be how to deliver better care to this person using telehealth, telemedicine technologies. Who wants to go first?
I'm with A-Frame Digital. Many of you out there, I see a lot of familiar faces, but just to give you a little idea of what we do, we have a watch that folks wear that tells you a number of things. It serves as a PERS device. It does automatic fall detection, does activity tracking. It can be used as a wonder management tool, and it also integrates to additional devices like a glucometer or a blood pressure cuff or a pulse ox, etc. And what we do is we pull in various pieces of data depending upon what individuals' needs are, and then we trend and alert on that data over time. So this scenario that we're looking at here is a very familiar scenario to us. And what happened is that this woman had persistent UTIs, and so she had a regular signature of what a potential UTI would look like. And so this is actually a study that we're very familiar with. And so by collecting her data and trending on it, we would be able to come up with a signature of what it would look like. Now, what would that entail? What would I need for her? Well, we know Mrs. Smith is a fall risk because she is susceptible to UTIs and she's fallen before. So we would definitely want her to wear a fall detection device. And I know there's a lot of pendants out there, but I don't know if you all know this, but 4 out of 5 times someone cannot or will not push that button, okay? So with 20% ROI is a little scary, yet it's saving many, many, many lives. And the faster we can get them that care, the better served we are. So she's susceptible to UTIs, we want her to have the fall detection. The other thing that she needs to do is take her blood pressure and her glucose every day, twice a day. How can we collect that? Well, this woman actually wrote on a pad every single day these calculations. But how often does she get to see Dr. Daffin? If he could get those streaming differences of the onset of a signature of a UTI by collecting that data via Bluetooth and automatically porting that into the system, he would have been able to spot that. And it's important, very, very important that you understand that the system isn't diagnosing anything. I don't think any of us would claim to do that. The systems that we work with are alerting you as to changes, and it's up to the professionals to make the diagnostics, okay? So those are the solutions that we would wrap around that.
Hi, my name is Cleisha Taylor. I'm the founder of American Healthcare Professionals. I am a registered nurse. We've been serving the Northern Virginia area since 1995. We do a telehealth program, but we're also a home health and hospice company. Yeah, I think this is great. This whole everyone coming out here and talking about Mrs. Smith, which is a common problem. I've been in nursing for 27 years. So for us who are in the healthcare field, this is a time that we've been looking at how can we do healthcare better. So what we would do first, and going back a few steps first, before we get to Mrs. Smith, is we need to know, we need to work with discharge planners. We need to work with doctors. We need to work with the place they're coming out of and going to. That's the first step, we go back. Then at that point, we reach out to Mrs. Smith. And with us, with telehealth, is what we're doing here, is we have to explain to her our teleprogram. What is the teleprogram? And fortunately for us, we've had a 95% conversion rate. Many people are adapting this, and once we explain to them the simplicity of it. Big thing about telehealth is that if it's expensive, then you've got to shift the cost to the client. So there you're back in the same cycle of too expensive healthcare. So the first thing we're looking at is a cost-effective way to manage this client. So now after we've identified Mrs. Smith is going to, accept this, this into our home or wherever she's living at, we will then send out an installer who will install the system, and then we would send out a nurse. At that point, a tele-nurse would go out there and assess the client to find out, certain things that are going on. What we find out is a lot of clients are falling, a lot of clients are depressed. So we create what you call an enhanced dialogue. So we put in certain questions into our teledevices. So not only are we monitoring vitals, which is a piece of it, we're also asking questions. So we would say to Mrs. Smith, did you do your blood sugar today? Did you, not your blood sugar, did you take your medication today? Did you fall? These things will also trigger a response to our call center. And at that point, our nurse would see, okay, Mrs. Smith is not, taking her medication. Well, this is why. Why didn't she take her medication? Well, in this case, she lives in an assisted living, but many of our folks are going home, and their daughter doesn't live near them, so they got discharged, went home and said, well, I'll wait till my daughter comes and visit me 3 days later, and I don't have medication. So she would therefore not be taking her medication. So immediately from the question, that triggered us without her even doing the blood sugar. Blood sugar would indicate her numbers going up and down. Congestive heart clients, same situation. A lot of them will come home and think they're doing a great job and says, well, I want to eat healthy, so I'm eating soup every day. That's the one thing congestive heart failure patients should not be eating is soup because of the salt content. So a lot of it is like Dr. Allen is saying is that, Dr. Dappin is saying is that it's nutrition teaching. It's things that a lot of people don't know. Now, we're also seeing the vital signs to help us to be able to diagnose this client. We're seeing if they're falling in services like Kelly's using. We are able to ask these questions and look to see if these persons are falling. So how we would manage it is by these things being triggered to our call center, our nurse through enhanced dialoguing, through seeing the vital signs, would then contact Mrs. Smith and try to manage it. But it's not just, it's working with the spectrum, it's partnershiping. We're all in partnership together, all of us together, to find out how to better manage her.
Did you want to talk about the Accountable Care Act and telemedicine, telehealth?
Sure. Yeah, the Accountable Care Act is, there's a lot of controversy, but it has a lot of components in it that many of us know and many of us don't. I happen to have read the entire thing. I don't know if a lot of people read it, but I did read it. I guess I have nothing else to do, but I did read it because this is where we're going. Now, is it right for us? There's a lot of controversy. There are some really great components in it. One thing we all know is there's a component about prevention wellness in it. Why we're trying to prevent, it's cheaper to prevent than to treat. There's a big component about telemedicine. One of the factors is, and I won't go too deep because then you guys go to sleep, but one thing is that, we know factual that Medicare readmissions are, I think it's $15 billion. $15 billion is in readmission. 12 billion could be avoidable. It's preventable. So the data is saying that. So what the government is saying too is, listen, we're going bankrupt as a nation if we don't change the way we do healthcare. Fact. Again, telemedicine, telehealth is not the answer. It's part of a tool to be used to help reduce hospital admissions. And we know in 2012, in October, all of us in hospitals and institutions are going to be penalized for readmissions. So one of the things, and we know is going to be 1% first year, second percent is 2%, 3% the third year. How do we reduce those admissions? And that is where the Affordable Care Act is looking for. They are talking to insurance companies. Certain states like Virginia is one of the states that is now mandating their insurance companies start to include telemedicine in the program to be reimbursable. But again, there's a savings because the organizations won't be penalized because people keep getting readmitted. And we as Americans won't see our dollars continually go up. 16% of the GDP is in healthcare and climbing. So this is a proactive thing. What are we trying to do with telehealth, telemedicine? We're trying to empower clients, individuals, to manage their care. A lot of them don't even know what a normal blood sugar is, what a normal blood pressure is. So that's where we're coming at. We can see real-time data right at the moment of it. And we don't have to wait till they come into the emergency room. We just heard a conference the other day, and one of the speakers said that the case manager in the emergency room is the most expensive case manager for healthcare, because everyone's coming into the emergency room with a crisis. In our devices that we use, one of the big things, and you all know, 40% of readmissions are related to depression. So a lot of the conditions are coming out of that, so we've got to get to that. So the Affordable Care Act is looking for models. They're looking for models of ways to keep down admissions into hospitals, into organizations, not to break this revolving door. So it's exciting, you know, partnering with insurance companies. We are doing that now in Virginia, that are piloting. We've reduced 60% of readmissions since we started the program in 2009. 40% that have been readmitted, 25% were not related to their diagnosis. It was infection, or they had a scheduled surgery. And why? Because we're able to get to it early. But it is a lot going on in the Affordable Care Act. Afterwards, if you guys want me to speak about it, you know, privately, please feel free to ask me.
Did you want to put up the next slide?
Yeah, actually, I have a couple more questions. I'm the kind of the moderator. I'm Beth McNamara, and I work with Doc Talker. I'm their strategic development director. But my next question is actually for you and Cleisha, Alan, you and Cleisha. So with telehealth, how and when would you get Alan, Dr. Dappin involved from a telemedicine consult standpoint?
That's a great question. When to use it. Specifically, and it also depends on what is your goal. Let's not chase the technology. What are we trying to do? What are we trying to manage? One thing we, as a particular, our specialties are what we're looking at, and other ones may be different. We're looking at chronic conditions, hypertension, diabetics, anyone congestive heart failure, COPD. We're looking at people who continually get rehospitalized. So what would trigger Dr. Al and Dr. Dappin to contact us is what he would say, that this person continuously goes in the hospital and I want to get a deeper picture of what's going on for them. I need more dialogue. I need more monitoring. See, we're seeing it as soon as you do your finger stick, we're immediately getting it. It's not, later, and we can immediately, it gives us a red alert. Immediately I get a red alert that your blood sugar is higher than what the doctor wants it to be. And therefore now I'm not going to call him, because we know discharge planners and doctors are overwhelmed already. So if we keep calling them with information, that's going to continually overburden them. So we have set up parameters, and that's when we work with a doctor to help him manage those that are going back and forth and that need some extra help. This is not a permanent solution. It's until we get to the goal with that person. And then we can take it away and we use the device for others. Some people want to keep them, and that's an option.
I actually have a question for you, Alan.
Okay.
So can you explain the difference with telemedicine and when you go out and see somebody? For example, are you giving medical consult via telemedicine for first time only, or is it after you've seen somebody? What's the policy?
Yeah, thanks. Yes, the way our practice works is I always say we are a local practice. We want to know all of our patients, and we're not a taking care of people that we've never met. So we always insist on a first visit, that anyone who's going to use our practice meets us. If they need to be seen, we're going to see them, whether they come to our office or whether I have to go to them. But after they know me, we are doing as much as we can on the phones if that's agreeable to the person I'm working with. So there's a lot of situations. We have many visiting nurse organizations that are seeing our patients on house calls, and they will call us periodically. We answer the phones, the doctor answers the phone in the practice, and by talking to the nurse immediately, we're able to kind of make adjustments on Coumadin levels, or the nurse, by the way, often is making the diagnosis for us. She just can't get the treatment done because the person can't get out of the house, and they need a doctor to okay a prescription or to renew a medication. So we're able to do that right away. I mean, if the nurse says, hey, this person is doing this and this, what do you think? I think it might be a urinary tract infection. It's like, hey, that's a good guess. Why don't we treat her, grab a urine on the way out the door so we can test that, and let's start her on antibiotics while we're waiting for the results. So we're not waiting to find out that she fell and ended up in the hospital, which is a common scenario because of those delays. So.
Actually, I have one more question, and that's really directed towards Kelly. What you do, is it primarily for home? And this is for everybody, actually. Is it in the home only? We hear a lot about going to the home-based, whether it's house calls, whether it's telemedicine solutions, but can you adjust this and really apply it towards independent living as well as assisted living facilities?
That's a great question. I think a lot of people are under the guise that it is intended for those that are living independently. And of course, that is where we can make a significant impact as well, because they don't have someone as readily available. But we encounter situations in our facilities where someone's living in independent living and it still falls and lays there on the floor for 20 hours until someone notices that they've not left their apartment. So the application is widespread and through the continuum of care. But I will share with you, our fastest growing segment at this time is in skilled nursing and rehab. And it all has to do with what Dr. Dabin was saying about that readmittance to the hospital. Folks are utilizing it to differentiate themselves and provide a totally different level of care to their customers. And then while they're in the care of the rehab facility, which is on average 3 to 5 weeks, shall we say, they're able to get that diabetes under control, start to educate the client and support that effort on those devices. And then when they go home, hopefully, right? When they go home, they take their own little home kit and they set it up in their home, and now they're used to it. They've formulated that habit. So that's really, really a key component, but it is a total continuum of care. We want folks to stay where they are, wherever that is today, as long as they're safe and healthy.
The other thing that I think is that I find always difficult are the questions about being paid, because while many of our ideas are, I think, obvious and don't really require that much scientific scrutiny because it seems very clear why we do what we do, the hardest part of it is how do you get paid to make a living so that you can do these things. And this is a problem that I'd like to ask Cleisha and Kelly specifically. I know how I get paid. I just said to myself, I can't keep waiting for someone else to determine to tell me how to do my job and to keep waiting to be told how to do my job. I got to do the right thing for the right reason. So our business model works on people pay us directly for service, just like a mechanic or a lawyer or a plumber or any other service economy job in the entire country. I just changed my model to that. Pay me to do the right thing for the right reason. I can make your care better, and I can actually make it less expensive than the insurance model. It's just that it's not subsidized by the insurance, unfortunately.
I should answer that question that Beth said, and then I'll answer that one. The first question about are these tools used for just homes? We even have a kiosk. It could be multi-users. It could be used in a subacute unit. As they're coming home, they're getting used to, as Kelly said, get them using this, becoming empowered before they go home. So they don't have to be used. They could be used in any organization as long as they have a phone line or broadband. That's how ours can be used. The key thing I want to get across is a partnership. And there are times that we can't, we need to bring other people in, everyone in, to bring in certain things that are going to make this client, wherever they're at, have the best quality of life and be able to stay there. Because all of us want to stay there. None of us want to go into a place that's not our home. So that's the first thing. As far as your question, Dr. Dabin, about the financing, again, it's a new industry, so it's like when pharmaceutical products came on the market, that wasn't originally reimbursed by our insurance companies, and later they added that. So we're showing it to be effectual, and we're showing it to be something that is really going to help bring costs. You'll find more and more reimbursing in it. We do reimbursements in it. We're doing right now, we work with insurance companies, we work with organizations, we work with clients. Again, the whole purpose of this, and this is what I can't stress enough, is to make the technology affordable. It's not all the whistles and bells, and you spoke about it. You get too fancy, somebody's got to pay it. And that is not our goal. Our goal is to be able to get information and to a point where people can afford it. And so that's how we work with it as far as cost. And again, it's changing in our government. We're finally getting it. And they're starting to now look at models that will bring down readmissions and help people, and they'll be able to reimburse for that. And again, a lot of our clients actually are paying for it because they see the benefit.
Do you have any more?
Cleisha and I are in a very similar situation as far as reimbursement goes. But I will tell you, I read an article yesterday that California was the first state to approve telehealth telemedicine reimbursement yesterday. So, so that, you know, everything is moving in the right direction. And when you look at the math for it, someone might say, you know, well, to afford that, well, how much does that fall cost them? Because we all know that the Medicare isn't going to pay for the whole portion of it. So those are the things that we try to get people to do. And more importantly, how much better can they feel?
That's all for my questions, so I'll open it up to your questions. I'm going to pull up the next slide, which is just a thank you slide. But it also has my email address there. If you want a soft copy of this presentation, I will be glad to email it to you. So if you don't mind just jotting down that and sending me an email, I will get it right off to you. So I'm going to go ahead and open it up to the floor so you can ask the panel questions that you want.
What would it cost for somebody to come in and have a consult? What would that cost actually be? And can I assume that you're charged by the phone call? So what if a patient has to call the doctor twice in one day? Is that a charge for each call, or does it go by how much time you have to spend talking to the patient? I'm just want some dollar figures. That's what I'm after.
They're very good questions. So we charge by time. So our entire business model is I get paid only for time, so that you can police my bill, and so that we charge $300 an hour. $300 an hour. So it ends up being that a 10-minute phone call which is a very common time. The 10-minute charge is probably our average charge, is $50. So you can take care of 50% of your healthcare problems, be it I need a refill on these medicines, that would be 5 minutes, or I need my cholesterol medicines changed, or I don't like this drug anymore, it's not working for me, or I have a urinary tract infection because I've had them before, or I have a sinus infection, or I have bronchitis, or there are a whole sundry of problems that we can solve in 10 minutes on a phone call. If people call twice in the same day, if it's related to a screw-up I made, then there's no charge. If it's a screw-up because you need more questions answered, then you're going to pay me. I always tell people when they challenge me on these questions, if you don't want to pay me to stay in business, to do the right thing for the right reason, and you think I should be free, then you need to go find healthcare in the healthcare system where you might think it's free, but it is not. So that's how I've gotten kind of obstinate about this, but it is hard to make a living having done this for 8 years, doing what I do. I work really hard, and at the end of the day, we're just trying to stay in business. So
his invoices are able to be submitted to insurance, okay? So that is a very important thing to note. So reimbursable is all relative, it's just not directly at that given time. Does that make sense? Is that correct?
that is correct.
Okay.
And I would also argue what we try to do is let people know day-to-day healthcare, the paying the doctor to get what you need is actually not the expensive part of healthcare. I'm the least expensive part of the healthcare system. So when it comes to paying my part of the bill, it's very tiny compared to the drugs and the tests and the consultant and the emergency room visits. And for those things, we always say, we're not trying to say you don't need insurance. We're just saying we believe that it's highly inefficient to use the insurance model for every little boo-boo and every little cut, because you're going to go through a gauntlet of hundreds of people in order to get any little thing taken care of. And it's not just a $20 copay you're paying. You're paying a lot of money for every little tiny thing you need to have done. And we believe that our model just cuts away a lot of that junk and makes primary health care more accessible and a lot less expensive than what is being paid for under the insurance model.
You mentioned UTIs, you mentioned monitoring blood sugar and blood pressure. And my question is, you know, blood sugars and blood pressures are all over. What would point to a UTI if you're seeing a blood sugar spike as opposed to somebody ate piece of pie?
I'm going to let the nurse answer that after I fill this in, okay? Because I can't make that claim to fame. But here's what this particular person, what was happening with that particular person. We were able to come up with a signature of previous UTIs that she had had, and look at the data for the signature of what that UTI looked like. And then we were able to alert the staff at the second or third day of the infection, before the resident even felt bad, so that they could take a proactive stance and say, oh, goodness, Mrs. Smith's signature of her potential UTIs has come up. So remember, we learned a lot about that resident prior to the first time we were able to do that. But I'll let you get more technical.
Thank you. Yeah, you know, I think, and this was a case study from Kelly, from a real case, correct? You know, with UTIs, again, I think for us, we would know it, and we would certainly, when we were assessing it, if they're prone to UTIs, is we would definitely make that part of our assessment, part of our enhanced dialogue. We would have a question to indicate, what is your temperature? Now, there are applications you can use as a thermometer to see if they're running the temperature, but for the most part, our particular tools that we use would not detect a UTI, but in the process of assessing it and asking questions, it may trigger us to go deeper. The only real way to diagnose a UTI, you know, is would have to have a culture sent in. But it may be some confusion may be developing. There may be certain along the way that would trigger it to us in that process.
You all have mentioned applications of telehealth, telemedicine in terms of monitoring people's health and being proactive in responding to problems before they might even know they have them themselves. Do you see any application in the telemedicine, in the telehealth field for proactive reaching out to the patient, for example, to help them be compliant with their medications if somebody's not regularly compliant with that, or assisting them with remembering medical appointments or therapy that they're supposed to be doing themselves at home, that type of thing, reaching out rather than just monitoring?
Absolutely, that's a part of both of our programs, as far as being able to take that positive step forward, because we never wanted to keep pinging them for just negative things. As a matter of fact, we would want to call them if their glucose is improved. Great job, whatever you're doing, keep doing it. It's just like the wellness side of the business. Are you familiar with the Biggest Loser, the show The Biggest Loser? Is everybody watching? Because I do. I love reality TV. So it is a device that they wear on their arm, and it's built by Biomedia. Is it, Cindy? Biomedia. And it measures your caloric expenditure, not your intake, Steve. Whatever that one is, I want it. But it keeps you honest, and it gives you that positive feedback. So those of us that are well, that's a tool that they use in wellness to that regard. But it's absolutely imperative that we, reach out, and if they've not taken a medication by their given time, or haven't taken a glucose by a given time, an alert can be produced to allow that phone call or reminder to happen. So, or if they've not left their bedroom, by 9 o'clock, which is their normal time, and it's 11 o'clock, again, we can take a proactive stance and call and say, "Good morning, Miss Kelly, how are you today?"
Yeah, that's a great question, because medication and what you just listed are big issues. Absolutely. We have a tool, a medication dispenser, meaning that we would know someone's not taking the medication. The key is, that goes back to the beginning, what are we trying to do with that client? And the assessment is the most important part of it. Once we assess what we're trying to do, then we take what tools are out there. Again, I like to use the analogy of a plumber. Until he knows what he's going to work at, he's not going to bring a drill in your house until he knows he needs that tool. What tools do we need based on the assessment? And that's exactly, a lot of medication is a big component of it. And yes, we do have applications, and there are many applications that work alongside of that. Big component also is the electronic medical record of it, the algorithm, so we can see the changing in places. But there would be, back to the medication, there would be alerts that would send to us that say this person didn't take the medication. Or if their pulse is too low, certain medications we don't want them to take. So we'll say, don't take this medication. So they would get a call from us. Nurse will call you. and we'll say, don't take that medication, your pulse is too low. So these are things.
Well, like Felicia said, that it depends on what your individual needs are. A-Frame Digital manufactures a watch that folks can wear that give you all of those capabilities that I talked about. When we get into vitals measurements, we would want to add things like a blood pressure cuff or a pulse ox, and that's exactly what both of us do. You know, adding that into the encompassed system. So you can start with the basics, and then as your health changes, add the individual components as needed, or even if it's just for a term, right?
Statistically, when a senior turns 65, 1 in 3 over the age of 65 have a hearing loss. 2 out of 3 seniors over the age of 75 have a hearing loss. So my only kind of underlying concern about all this with use of teleconferencing is the potential for seniors to have a misunderstanding on the telephone, especially if they don't have a proper phone for people who don't hear well and they're struggling to hear on a regular phone. I'm also concerned about deaf seniors who have to go through relay. And do you have a system in place to treat deaf seniors who have to go through a relay system?
So we don't have a specific program per se for or anything written in hard letters on this question. So they're very valid questions. I would say that there are for the people who are hard of hearing, just seeing them face to face doesn't guarantee that they're going to hear you or understand you any better. And so I'm not convinced that it rules out the capabilities of telemedicine at all. In fact, I would say that it probably has very little to do with the existing model as it exists today, whether telemedicine is going to work for the hearing group. I would think that these are questions that are really valid and probably need to be addressed in a way where a group really looks at it systematically to try to improve our ability to do that right. And I'm not going to say I have a great solution. I know the few people I've had who are deaf often have to, we have to do it through typing back and forth to each other, and we can do that. We certainly can use that technology. So it's a little bit like we do each one individually based on what we think is wrong, based on the individual uniqueness of that person. Yeah. I would also make one plug for anybody who is interested in telemedicine. If anyone is interested in this at all and has not joined the American Telemedicine Association, I really think they're a very worthwhile, of the American medical systems out there, I really believe that they're one of the few groups out there trying to actually work on reframing the question of how healthcare gets delivered in the country. And I think if there's anybody at all interested in looking at telemedicine in general about their business or how they do work, that it's a really worthwhile organization to join. They're out of DC, the American Telemedicine Association. It's a really good group of people, and it's mind-boggling how many companies and technologies there are out there. It just stunned me of how much there is. So it's really worth looking into, especially if you're looking for telemedicine solutions.
Okay, one last question.
Hi, my name is Sarkala. I'm from First American Home Care, and I'm an owner and an RN also. A couple of years ago, I invited one of the local telehealth representative, and I was very shocked to see how expensive to have a telehealth. And you know, we as a nurse also understand, you know, the avoiding the readmission rate, and we do have one of the lowest readmission rate in the hospital. I know Virginia has like 25%, and national is like 27%. Ours is 19%. But you know, I would really like to work with telehealth, but it is very expensive. How close are we convincing Medicare or the insurances convincing that the correlation between, you know, saving the money, using telehealth to keep patients from hospitals?
Wow, that's like an amazing question, because that's exactly what I went through. Because it was so expensive, I'm like, well, that means the costs are going to be too expensive for the client. You have to shift the cost, so we're back in the same boat. The key is, how close was your question? We're getting there. We're getting there because we're doing a lot of pilot studies. We've got to convince them that this is something that's going to save money, which we are. You know, and that's why it's actually on the Affordable Care Act. This is actually on it. Telemedicine is on the Affordable Care Act, and this is part of what is going to be reimbursable. So the good news, it's there. Many insurance companies are not compliant yet in the state of Virginia and other, it's like 10 states that came along and said they're going to do it. They're not compliant yet. Now we're working with Blue Cross Blue Shield. They're trying to create a code for it so they can bill it. So this is what they want, this because they see the numbers, they see they're reducing it. Yeah, and the key is, you know, again, as the most thing, that a big thing I learned, I was researching this for 4 years before we started a program, is that you have to decide as an agency, what do you want to do? What do you want to do first? And then from there, we start to look at the technology that you need to accomplish what you want to do. And so that is so you don't go out and buy a lot of expensive stuff that you don't need to do. And that's the key. A lot of us just call it the whistles and bells, and beautiful videos. We don't need all that. It's something as simple. Ours is a regular blood pressure machine, a regular glucose scan. I mean, it actually could be used any part of the house. And it feeds into a Bluetooth. And that sends the information like a fax to us. So it was a simple and it was costs that you built into when you program. But yes, it is difficult for companies to bring this in. Some other ones may not ever want to bring it. Then you subcontract a company to do your monitoring. It depends on what you want to do.
Well, we have been enlightened and enthused with this kind of information. Certainly it's on the edge, and we'll be hearing much more about this as healthcare legislation passes. So I think this is deserving of a round of applause for our panel. And we are very grateful that we could have such expertise, in fact, industry-leading expertise, come and for free just to enjoy this kind of information. So we are really indebted not only to the panel, but to the Virginian who provided us an incredible lunch, and so we're grateful there as well.